sharing of the latest technologies and information on management and leadership. I am Alma Jimenez. I am one of the moderators for today's forum, and the other moderator is, of course, my chair, the chair of MAP Health Committee, Junie Del Mundo. So on behalf of the MAP Health Committee, I would like to call the forum to order.
Good afternoon, everyone, and welcome to this health forum, and thank you very much for coming over despite the bad weather. This webinar is part of a series of learning programs offered by the MAP CEO Academy for our members' professional development. This forum dovetails with the programs of the MAP Health Committee to boost public health by providing a discussion arena and dialogues to provide information health risk management so that organizations can create and upgrade their own programs and policies and help strengthen the health system. This afternoon's forum will focus on the government's plans in and make quality health care accessible to every Filipino. Let me thank Alma Jimenez for putting this forum together and for moderating today's session. Alma is Vice Chair of the Health Committee.
Thank you, Junie, and to everyone joining us this afternoon here and face-to-face or and online. So, can you just flash the slides, please? There are three major components of a health. The patients who need the care in various stages and complexity, the providers that include individuals like doctors, and institutional like hospitals and clinics. And of course, we have the health financing, or those who fund the care. The pandemic magnified the inadequacies of the global healthcare system, as seen in the uncoordinated crisis response and the imbalances in financing healthcare that made access to the services challenging. We have a healthcare sector that is far from perfect, and the strains will be more glaring as we gradually turn from epidemic to endemic status and start the recovery process. We will most likely see surges in utilization as the postponed procedures at the height of the pandemic will now need to be done. The impact of this backlog will further tax the health system. And given that the economy has yet to recover, patients will find it difficult to shoulder out-of-pocket health expenses, while many employers have yet to find their bearings. This forum today hopes to provide some answers as we try and figure out how to make quality healthcare accessible and affordable. But the question is, who's picking up the tabs? I know you're eager to hear our speakers and reactors weigh in, and we will get there shortly. But first, let us frame the issues by taking a look at how the men on the street think, or women, men and women, para may gender equality. Let me call on the chair of the MAP Health Committee for his opening statement and situationer.
Health has been on the forefront of Filipinos' minds in the past couple of years, specifically having accessible and affordable health care for themselves and their loved ones. This prompted us at ION to wonder how Filipinos are coping with the cost of health care and who or what has been helping them pick up the tab. One answer to the second question is the Philippine Health Insurance Corporation, or PhilHealth, the government agency mandated to oversee the provision of health insurance coverage and affordable, acceptable, available, and accessible healthcare services to all Filipinos. But with PhilHealth making headlines and trending online in the past 2 years for reasons ranging from corruption allegations and missing funds to increased collection rates, we wonder if Filipinos still see the agency as trustworthy, given that its role of handling member contributions to ensure accessible health care for all is founded on public trust. Do Filipinos still find PhilHealth reliable? Today, we present the findings from our research on the Filipinos' perception of PhilHealth. In putting together this presentation, we relied on two different approaches. First is through a quick pulse survey that Ion Trust Central conducted from July 28 to 30 through the Tangere app. Second is through our groundswell report, where we monitored PhilHealth online mentions on various social media platforms between August 1, 2021 and July 31, 2022. From the survey, we had 2,000 participants, 66% of whom are aged 40 years old and below. Nearly half of them come from Luzon, while 30% reside in NCR. More than a quarter of them earn 10,000 pesos or less in a month. Let us proceed from what we learned from our research. Our study reveals that Filipinos in general know about PhilHealth. 100% of the 2,000 survey respondents know of the agency, including the 120 who are not PhilHealth members. This high public awareness is unsurprising since the pandemic has put the country under an unprecedented health crisis. More than 75% of the respondents believe the agency contributes to public health and welfare. Furthermore, 59% of them see PhilHealth as both visionary and protective of public interests. More than half of the survey participants also agree that PhilHealth is a good steward of its resources despite allegations of corruption against its previous leadership and is a catalyst for positive change. In terms of its performance and competence, 55% and 54% of the respondents rate it favorably. Less than half of the people surveyed, however, believe that the agency is fair and honest, indicating the effect of PhilHealth controversies on its public perception. Majority of Filipinos also still trust PhilHealth and its services. Distrust, not distrust, comes despite the negative publicity that the agency received during the 2020 Senate inquiry about the alleged misuse and abuse of 15 billion worth of contributor funds. According to the survey, the agency enjoys a 61% trust rating from the respondents, with only 20% having no opinion on its trustworthiness or lack thereof. However, this expression of trust is possibly already impacted by the controversies that have surrounded PhilHealth in the past 2 years. According to the 2019 Philippine Trust Index, the agency had enjoyed an impressive 92% trust rating. That number dipped to 89% in the 2021 PTI. The trend seems to be that while PhilHealth continues to enjoy a significant amount of public trust, its perception of trustworthiness has been declining through the years. To get a more nuanced understanding of what drives respondents' trust in PhilHealth, we asked them to rank several factors. The top trust driver is PhilHealth implementing policies and programs that provide health protection to its members. This supports our observation that the role of the agency plays in society contributes a lot to the public perception of it. The implementation of programs that widen its scope of benefits and its treatment of employees according to what the law mandates also rank high as their trust drivers, followed by PhilHealth's timely provision of benefits and agency staff proper treatment of members who visit their offices for assistance. The trust driver that ranks last among the respondents is PhilHealth having respected leaders and its management, an indication of their level of awareness of the 2020 Senate inquiry in the agency's leadership. Based on their answers, the respondents' trust in PhilHealth is informed by their actual experiences in dealing with the agency, as we'll see in the next slide. Across all the agency's operational attributes, majority of the respondents gave PhilHealth a favorable rating. It scored its highest approval for its clear communication of its services, policies, processes, and requirements, followed by its accessibility to members. PhilHealth staff are also perceived to be knowledgeable and service-oriented. Both their delivery of services and program implementation rated positively among 57% of the respondents, and 55% believe that the agency continues to pursue improvements. Since PhilHealth's communication measures are highly rated by the respondents, we also checked to see the channels they most commonly rely on for information about the agency. The top three are television, the PhilHealth website, and social media platforms such as Facebook, YouTube, and Twitter. The generally positive experience with PhilHealth doesn't mean that Filipinos agree with the agency's recent measures, however. For a brief background, in April 2020, PhilHealth announced new case rate packages for COVID-19 patients and ceased paying for their medical care at cost. These had affected survey respondents who have had COVID infection or okay. This has affected survey respondents who have had COVID-19 infection or had family members get sick with the virus, with a number of them saying that they received inadequate support from the agency. The majority of survey participants also disagree with the new premium collection rate that was announced in May. Given how Filipinos are already struggling with rising prices for food and fuel, the new rate, which went from 3% to 4% of a contributor's basic monthly salary and will be applied retroactively from January to May, is another financial burden, especially for those earning minimum wage. As we can see, the respondents don't agree with the increase, and only 18% see its point. Plus, with COVID-19 as a prevalent reason behind the illnesses of hundreds of thousands of Filipinos during the pandemic, only 37% of the respondents say that PhilHealth has adequately covered their healthcare needs, while 63% say that the agency's support was inadequate during the time when they or a family member became sick with COVID. Since the allegations of corruption and the recent contribution rate hike didn't seem to play too much into the survey respondents' perception of PhilHealth, we also looked into the online sentiments of Filipino netizens regarding the agency to see if they complement or reflect what people on the ground are saying. Between August 2021 to July 2022, there were 41,115 PhilHealth-related mentions online. There were two visible spikes within that period. First was in August 2021, driven by digital news articles on PhilHealth's implementation of a circular that suspended the payment of its members' hospital claims. The second was in May this year, when netizens reacted negatively to the new PhilHealth monthly contribution. In addition to these two issues, the controversy over the agency's 15 billion funds that were allegedly stolen was also a hot topic online. These spikes come from a variety of sources. Online articles reporting on the suspension of payment for hospital claims, the alleged 15 billion missing fund, PhilHealth's coverage and benefits for its members, and the topic of the new contribution rate contributed to 27% of its mentions. Social media reactions to these news items, particularly the increased contribution rate and the so-called stolen funds, further added to the volume of the agency's mentions. Filipinos also shared online their experiences in applying for a PhilHealth membership, including the inquiry process, as well as the agency's coverage and benefits, and the politics surrounding it. There have also been reactions to the requirements for students to become PhilHealth members first before resuming face-to-face classes. Looking deeper into the published news regarding PhilHealth, majority of the online articles were news about the reconsideration of its circular that suspended payments of hospital claims. On the part of netizens, most of their mentions of PhilHealth expressed dismay over the increase in its monthly contributions. Some even connected the new rate with the so-called stolen funds of the agency. However, in analyzing these online sentiments, also less than a third of them were negative. They are still mostly neutral, driven by online articles on the agency and inquiries and discussions among online users about its benefits and coverages. Government is the predominantly key word in PhilHealth's mentions, followed by country and hospitals. The first two drive home the agency's critical role in implementing universal healthcare coverage for Filipinos. The latter, meanwhile, along with the key phrase, private hospitals, showed up in news items regarding the suspension of payment of hospital claims due to suspicions of fraud. Other notable keywords are percent and money, relating to the alleged stolen PhilHealth fund and increase in membership contribution. We gathered some sample PhilHealth mentions from social media accounts of news organizations and ordinary citizens. Even with these samples, the topics that drove the spike in PhilHealth's online mentions during the period covered by our social listening activity remain consistent. The higher contribution rate, the 15 billion fund, and the suspension of payment for hospital claims. In comparing both the survey and the social listening results, it seems that while PhilHealth's controversies driven online conversations about the agency and evoke negative sentiments from netizens, they aren't as quick in affecting the general public perception on PhilHealth's trustworthiness. Still, when we apply an even broader look at how Filipinos view PhilHealth, there has been a downward trend in public trust through the years. There might not have been a dramatic decrease between 2019 and 2021, according to the Philippine Trust Index, but the percentage of respondents who expressed trust in the agency in this particular survey is an indication of how PhilHealth's actions on the past 2 years have affected its standing. What this study tells us is that despite recent issues on how it has handled contribution funds and the negative reaction to its latest measures, PhilHealth's essential role in the national healthcare system make the Filipinos' reliance on it inevitable, compelling them to trust the agency and its services. But that doesn't mean their dependence on it can be taken lightly. With health, a fundamental human right, providing citizens with access to proper and affordable health care is the government's legal obligation to the people. PhilHealth must strive not just to correct the wrongs committed by its previous leadership, but also continue to find ways to make quality health care accessible and affordable to all Filipinos. To help give the agency an idea of how to do better by Filipinos, we asked the respondents what their usual pain points are when trying to avail of PhilHealth services. While they have positively rated their direct experiences in dealing with the agency in particular, the clear communication they received from PhilHealth, respondents still cited the accessibility of all necessary information and the availability of guidelines as their top 2 points of friction. Even though PhilHealth's coverage and processes fall within the lower half of the respondents' list of common pain points, the aforementioned top 2 areas that most need improvement are prerequisites for accessing the agency's services. So are the top 3rd, which is accessibility of PhilHealth offices, and the top 4th, which is the functionality of its website. Although the higher membership collection rate has been a source of concern among PhilHealth members, it still registers as a last point of friction to the respondents. This drives home the point that Filipinos appreciate PhilHealth's role in society and that they are willing to entrust their hard-earned money to the agency in hopes that it will continue to help them access affordable and quality health care. That sums up our committee report. Thank you, everyone. Now, we would like to hear your thoughts and comments, or if you have any questions later. Thank you.
Thank you to Junie and to everyone joining us this afternoon. Again, as I said, it seems we are in for a lively discussion, so let's get down to it. May I just request our distinguished panel led by Dr. Shirley Domingo, Dr. Jose Rene de Grano, and Ms. Ellen Pulido to join us on stage so that we can start the ball rolling. In line with MAP policy and in the interest of time, we will dispense with the lengthy introduction of our speakers and panelists, but their profiles will be flashed on screen. With a reminder to our speaker of the 20 minutes allotted time for presentation, we will now welcome the spokesperson and Vice President for Corporate Affairs of PhilHealth, Dr. Shirley Domingo.
Thank you very much, and good afternoon to everyone. First of all, I would like to thank MAP for inviting me here, for inviting PhilHealth here to be able to discuss issues, benefits, and updates of your benefits. I was very glad to hear the discussion of Sir Junie there because it somehow is consistent with what I will be saying, so thank you for that. Okay. In 2020, PhilHealth was thrust into the limelight. PhilHealth was thrust into the limelight for not very good reasons. Our work, sorry, let me start this. Our work is because it's based on a provision in the Constitution that says health is a right of every Filipino citizen, and the state is duty-bound to ensure that all Filipinos have equitable access to effective healthcare services. This morning, I hope to discuss with you, some things about the organization, about universal health care, only a short few slides on universal health care as a context for the discussion of PhilHealth benefit packages, the expansion of our existing benefit packages, and of course, the way forward. In 2020, PhilHealth was thrust into the limelight for not very good reasons. 15 billion was allegedly pocketed by its executives, or at the very least misused. Congress was in high gear. The fact that it was happening in a previously scandal-free health sector made it more appetizing to media. Was this the big fish to finally be caught proving corruption in government? Bashings from social media and the public were relentless. So why bring this up now? Your organization, MAP, counts as its members a big number of employers. The employed sector, now known as the direct contributors, make up 63% of our membership base and contribute to around 53% of our total collections. PhilHealth's business is based on trust. Trust that the money you contribute will be used to fund health needs, not only of yourself, but of the whole population, being a social health insurance. It is in this light that I ask you to allow me a few minutes of my talk to address and provide clarity on the issue. The Interim Reimbursement Mechanism, or IRM, was conceptualized in a scenario where a health crisis was imminent in our country. A health crisis that no one in the world had any experience in controlling. A virus was our enemy. We did not know where in our country the enemy will strike. We were ignorant on where and when it will manifest itself. Being the financing arm in the health sector, the knee-jerk reaction was to ensure that health facilities were ready to fight it. We had to make sure that health facilities had cash on hand and were liquid enough to fund any necessary action against COVID. Thus, the IRM was conceptualized. For those hospitals who applied for it, PhilHealth leveraged its funds to make sure hospitals and other facilities prepared for this oncoming crisis. We released funds based on historical utilization data. It should be noted that in universal healthcare law, whose provisions were already in effect, the provisions included shifting to global budget as a provider payment. The IRM can be seen as a precursor to such provider payment schemes. This payment scheme was lauded internationally. PhilHealth COVID-19 response was awarded with the ASEAN Continuous Improvement Recognition Award by the ASA, or ASEAN Social Security Association, in December 2020 for its efforts in COVID-19 as catalyst for evolving the payment mechanism towards UHC's progressive realization. Likewise, in an article by WHO financing experts, No Calm After the Storm, Retooling PFM in the Health Sector, it mentioned advance payments to providers as a complement to retrospective payments. Also from WHO financing team, in priorities for the health financing response to COVID-19, advance payments, which was what IRM was all about, to public and private providers to cope with anticipated increases in demand was one of the key health financing actions to support the objective of removing financial barriers to availment of health services. Meanwhile, here at home, numerous cases has been filed against PhilHealth employees and officers to date until now. The IRM has now been 99.93% liquidated. The remaining unliquidated funds are coming from 3 hospitals that either closed or have problems in liquidating their claims. Maybe there were procedural lapses in providing these funds to hospitals, maternity clinics, and dialysis centers. Pero wala pong nawawala. Wala pang opisyal ang yumaman dahil sa mga funds na ito. Through all this, the officers and staff continued in its mission of providing financial support to our countrymen in need. Your policy recommendations in the area of quality health care stated in number 1, to overhaul PhilHealth's leadership. Sadly, for me, this is an indication that the perception of corruption is still there. An organization is defined by its leadership. Leadership provides direction and the tone by which work is done. For me, this may be the very reason why PhilHealth is perceived to be underperforming. PhilHealth has been operating for 27 years. Okay. PhilHealth has only been operating for 27 years. An organizational child compared to other organizations within the health sector and compared to other social security organizations who have been operating for more than 80 years. Changing presidents almost every year. For the past 15 years, we had 10 presidents in the past 15 years, with some staying only for a few months, deprives the organization of continuity and stability. 2 very important factors for a well-performing organization. New leadership would mean starting learning curves, new directions, new priorities. With all due respect to your recommendations, what the organization needs now is stability. Career officials and staff in PhilHealth are well-trained, qualified, competent, and hardworking. We are hoping that a president is named very soon, so directions and decisions can be made and the organization can set its course towards successful fulfillment of the universal health care law. So this brings me to the next topic. What is universal health care? Okay, I will be discussing only some major concepts of universal health care. Universal health care is all about 3 dimensions. One is the population coverage, which is the extent of coverage of the population. This is answered by provisions in the Universal Health Care Law that says all Filipinos are automatic members of the National Health Insurance Program. So, done na itong provision na ito. Secondly is the service coverage. Are we providing enough health services to respond to the health needs of the country? The provisions on immediate eligibility and access, which is in the Universal Healthcare Law, answers for this, because you may be able to avail of your benefits even without necessary qualifying contributions, unlike in the past, when you had to be able to contribute 3 months out of the past 6 months. Ngayon, wala na. You can avail of your benefits kaagad. But, iba yung collections. We have to collect also from you because there are provisions in the law that talk about interest or 3% for the employers, 1.5% for the members for missed contributions. What other services are mentioned in the law? A comprehensive outpatient benefit, which we are already addressing at PhilHealth, and a provision of primary care provider. I'll talk about that a little more later on. The third dimension is financial coverage. Is the funding of health services enough to ensure that Filipinos are not impoverished when they need to avail of health services? So yun ang financial coverage. And there are lots of provisions in the Universal Healthcare Law to address this. One is the zero co-payment. 2 are the fixed, predictable co-payments. Okay. So what are the major strategies of universal health care? One is the provision to all Filipinos of quality, preventive, curative, palliative services with focus on primary care. So the Universal Healthcare Law brings us back to prevention and healthy living. That's what they encourage. And the law provides with the mechanism for us to focus on this. Second is promoting an integrated approach to healthcare delivery through healthcare provider networks and primary care provider networks. And the third, which is more of the PhilHealth's role, is institutionalizing mechanisms to ensure financial risk protection by promoting predictability of payments. No? And I think yan ang para sa akin, very important. No? Some people can afford health services, but it's very important that we know when we're about to avail of health services, how much will we be using. For example, ma-hospital tayo, no? Lalo na kung emergency. And then you go to the hospital, confine your relative, without knowing how much you will have to pay. Now, the provisions of this law puts a premium on predictability through fixed co-payments or co-payments, no co-payments. Okay. Sorry. I'm sorry. Okay. This slide shows the components of universal health care, Filipino style. I made this slide myself. It's just to show in one slide the important provisions of universal health care law. Universal health care law is a very extensive law. It is a blueprint for reforms in the health sector. It's just like when you're making a house, you need a plans and blueprint. Ito na yon, universal health care law. And of course, it's mentioned there that you cannot just build the house in one day or at a certain period. It's progressively realizing each and every component of this law. This law encompasses from primary health care, tertiary health care, clinical care, rehabilitative. It also talks about human resource for health, how to ensure that we have enough human resource, and it talks about a lot of other necessary features of an ideal health system, including education, complementation with HMOs, etc. So in short, components of UHC is based on the values of equity, quality, and affordability. And in the screen, I show you the provisions under equity. It's allocation of bed capacities for no co-payment scheme. There are provisions for geographically isolated and desolated areas. These are areas that It's encouraged to give grants for networks in these areas, incentives to be given for human resource, for health or medical practitioners practicing there, and preferential licensing for these underserved areas. As to quality, making sure that there's quality health services, there's the third-party accreditation, health technology assessment, contracting, licensing regulatory system, and provisions for clinical practice guidelines, CPGs. And as to affordability, there are provisions on co-payment, benefit rationalization, complementation between DOH, PhilHealth, private health insurance, and the HMOs, and the most important, affordable drugs and medicines. It has been noted that yung malaking factor for out-of-payments when you are hospitalized, it's the drugs and medicines. Yon ang pinakamahal, yon ang mas malaking linalabas ng pasyente. Therefore, we have to have mechanisms to be able to address affordable drugs and medicines. Excuse me. So in the law, there are provisions on National Price Reference Index, or NPRI, availability of generics, fixed markups, transparent pricing, price monitoring, independent price negotiation board. So, yon ang in a nutshell yung law. So what is universal health care for a PhilHealth member? One, everyone will be assigned to a primary care provider, and I'll talk about that later. Second, as I already mentioned, everyone is automatically a member with immediate eligibility. Third is the establishment of healthcare provider networks for easy navigation. And fourth, healthcare spending, as I mentioned earlier, will hopefully be predictable once we implement most of the provisions of this law. This slide will just show you, in a nutshell, how the organization of the healthcare providers or the health system will be at the local government. These are the components of the healthcare provider network, and it is also in the law that says PhilHealth, once this is established, will now engage with these healthcare provider networks through contracting, and that PhilHealth reimbursements will be pooled in a special fund by these healthcare provider networks. So as you can see, the network is made up of primary care facilities, hospitals from level 1 to level 3, and a single specialty, multiple specialty hospital, or the referral centers, or the Apex and End Referral Hospital. Is everything free in UHC, which is the most common question? No, not everything is free. However, However, there's a provision there that says that for those confined in basic ward accommodation, and this refers to provision, accommodation with provision of regular meal, bed in shared room, fan ventilation, shared toilet and bath. In government hospital, it's supposed to be no balance billing or no co-payments if you're confined in a basic ward accommodation. And it also says there that at least 90% of hospital beds in government hospitals should be a basic ward accommodation. In specialty hospitals, such as the heart center, the lung center, kidney centers, 70% of the beds should be should be basic or ward accommodations. While in private hospitals, at least 10% of the beds should be in basic accommodation. So let's go now to the National Health Insurance Program and the benefits. I'm sure, I hope most of you knows already about the basics of this. The benefit packages of PhilHealth, or service coverage, includes inpatient benefits, outpatient benefits. So it's not true. Whenever I'm interviewed, they're asking how can they avail of PhilHealth services if it's only for inpatient. No, we have also a lot of outpatient benefits. So we also have primary care benefits, which I'll explain later on. catastrophic or Z benefits, and some special benefits. As to the inpatient benefit or the all case rates, these benefits are paid to the accredited healthcare institutions through case rates. There are around 4,000 medical case rates and around 4,000 surgical case rates too. The case rate amount is deducted from the healthcare institution from the member's total bill upon discharge. And the case rate is inclusive of hospital charges and professional fees. Next, we have the outpatient benefit packages. So examples of this are the day surgeries, which is done in ambulatory surgical clinics. It ranges from minor to major operations depending on their accreditation level or their licensing level. We have radiotherapy, which we pay around 2,000 to 3,000 per session. Hemodialysis, and we have very good news there because we have expanded the sessions from 90 to 144 sessions this year. We have been expanding it for the past 3 years, and there's a clamor, and I understand why, to institutionalize it. Of course, we're studying this. We will, in the biggest probability, we will institutionalize this number of hemodialysis and might even expand it because some patients says that 144 sessions is still not enough for them. Nauubos na to bandang September, October, and they want more sessions sana. So we're studying this. Outpatient blood transfusion, 3,640 per transfusion. Catastrophic or Z benefits are the benefits to address medical and surgical conditions that has a big amount needed once hospitalized. No? Kaya sila catastrophic, catastrophic packages. Like, for example, leukemia, we pay 500,000, but these are in accredited hospitals. Not all accredited hospitals are authorized to implement these Z benefit packages because we first contract and discuss with these hospitals some of the provisions. So nakikipag-contract kami before they can implement this. So not all hospitals has these packages. Breast cancer or prostate cancer, we pay 100,000 per surgery. Kidney transplantation, 600,000. Coronary artery bypass, graft, 550,000. Tetralogy of Fallot, this is in children, 320,000. Cervical cancer, 120 to 175,000, and down the line. Colon rectum cancer, children with developmental disabilities, children with mobility impairment, and the Z-morph or some orthopedic implants. We have special benefit packages such as malaria outpatient package at 600, outpatient HIV/AIDS 30,000 per year, the TB dots 4,000, voluntary surgical contraception, and the animal bite treatment. Primary care benefit. This benefit is relatively new in PhilHealth. This is in response to the universal health care to provide or to shift to primary care as a strategy in the health sector. So we have what we call the PhilHealth Consulta. The PhilHealth Consulta gives access to our members to primary care services that include diagnostic and laboratory tests such as chest x-ray, fasting blood sugar, ECG, among others, if needed. So that will depend on the risk factor of the individual. Drugs and medicines for certain medical conditions such as asthma, diabetes, and hypertension. As of June, we have a total of 437 providers, which is not much. Kaya that is our limiting factor. We're still in the process of encouraging providers to be accredited as primary care providers. So we're moving fast towards that. Uh, Target services under Consulta includes the services of initial follow-up with a consultation with a primary care provider, targeted health risk screening. We have 12 laboratories, as seen in the screen, and some outpatient medicines if needed. What was the PhilHealth's pandemic response? We had several packages offered. One was the home isolation package. Although it was there, it did not take off much. Again, because of the issue of providers. There were some local government units that says that they did not need anymore a home isolation package kasi meron sila mga community isolation units. So, iba-iba yung response. So, hindi masyado nag-take off ito. Indemnity fund for vaccination injury, this was a separate law, and PhilHealth managed the 500 million that was given under this law. The DCPM, which was to fast-track payments to our hospitals, fortuitous events provisions such as the extended benefits, the interim reimbursement mechanism, payment of emergency room and tent accommodations, and partnership with entities to increase testing capacities. So we had provisions or benefit packages on testing, community isolation, home isolation, inpatient care, and vaccine injury. Accredited facilities. We accredit the healthcare providers that provide services to our members, hospitals, from infirmary dispensary up to level 1, and some facilities such as animal bite centers, ambulatory surgical clinics, drug rehab centers, TB DATs, freestanding dialysis clinics, family planning providers, maternal lying-ins or MCP package providers, HIV centers, Consulta, and the malaria providers, outpatient packet providers. So on your screen is the number of such providers. As to professionals, we have 41,030 physicians who are accredited in PhilHealth, general practitioners 9,932, specialists 21,965. We have other professionals, dentists, nurses, and midwives, totaling to 44,451 professionals accredited by PhilHealth. Okay, health technology assessment. Under the Universal Healthcare Law, all our existing benefit packages shall continue to be implemented or enhanced unless otherwise recommended by the HTA or the health technology assessment. So health technology assessment is now institutionalized because of provisions in the law. And they do assessment of new technologies, whether it's drug, medicines, equipment, processes. They will recommend to PhilHealth or the DOH the adoption of these new technologies upon their assessment. So that's the health technology assessment. It's already existing. It's being managed. It's a committee under the Department of Health, under the Universal Healthcare Law. In 5 years, it will become independent, and it will be moved to the Department of Science and Technology. We have already online payment for self-paying individuals. Just go to our website, My Portal, put in your number, the PIN, and you can view your contributions. You can print your MDR, which is the most common requested form, or the member data record. So you can go to this online facility. And you can pay online through this facility. This is just to give you some statistics. These are the top 10 procedures that PhilHealth pays for. The number 1 is hemodialysis procedure. This is expected because it happens several times during a year for one person. So it's expected that it will be the top procedure paid for by PhilHealth. So we paid a total amount of 14 billion. This is from claims payment from January to December of 2021. Total number of claims is 2.9 million. The second highest was COVID testing package. Marami kaming testing benefits that we paid out. Total of 6.3 billion and 2.2 million test claims. Second is NSD, normal spontaneous delivery. Next is expanded newborn care package, CS. Chemotherapy, again, because of repeated chemotherapy in a year. Cataract extraction, radiation treatment delivery, and DNC. These are the top claims for medical causes. Number one is also, of course, pneumonia. And then followed by, we paid 2.7 billion for pneumonia last year. Emergency hypertensive urgency, dengue fever, which is again rising now. So please be careful. Clean your surroundings all the time because dengue is rising again. Outpatient patient AIDS, acute gastro, UTI, admissible UTI, peptic ulcer disease, stroke, newborn sepsis, and COVID-19 pneumonia. As to claims payment of membership category, the highest was for, as I mentioned earlier, between the direct contributors and indirect contributors. The direct contributors' claims amount was higher than the indirect contributors at 48.4 billion. The indirect contributors, or the indigent, senior citizen, and sponsored and PWD, amounted to around 39.8 billion. With the informal self-earning sector being the highest in the direct contributors at 19 billion, followed by the employed private direct contributors at 14.3 billion. This is just the benefit payout for the pandemic years. In 2020, we paid, this is a comparison of the non-COVID and the COVID. 99% in 2020 was still non-COVID claims. COVID only was 1% of the total amount paid. Of course, this increased in 2021, 23% COVID claims compared to 77%, and increased further in 2022 as of August, 28%, 72% non-COVID. So we paid a total of 265 billion from 2020 to 2022. Of course, this is the paid amount. So this amount changes. It's every day the amount changes. Kasi nakakabayad na kami, may dumarating ulit, and then we pay it. So it's really a moving number. So this just gives an estimate. Support value. What is our support value? The average, of course, support value again varies depending on your type of illness and type of provider. No? Sometimes it's higher in the private, sometimes it's higher in the government. Of course, the type of illness like strokes is mas mataas yun kaysa pneumonia. No? So depende talaga sa type of illness and provider. But on the average, our support value is around 65.9% or 66%. Highest in the indigent sector at 79.5%. So a support value of 65.89% means that for every 100 pesos in hospitalization cost, PhilHealth shoulders around 66 pesos. Further, support value is higher in government, 79.3% compared to private facilities at 57.32%. So, I'll just discuss, maikli na lang ito, what are the policies in the pipeline in PhilHealth. We're working on implementing the no-co-payment scheme as indicated in the Universal Healthcare Law. We're moving towards a change in provider payment, the DRG, or Global Budget Scheme. We're working on implementing guidelines on the PhilHealth framework and costing of health services, network contracting, as I discussed earlier on. PhilHealth Plus, this is a benefit package addition to the basic package given by PhilHealth, but additional premiums. So that's the PhilHealth Plus. That's also in the Universal Healthcare Law. And a comprehensive outpatient benefit, which include consultations with medical specialists and emergency care. So what are the other benefits planned from 2023 to 2025? Expansion of hemodialysis, selected orthopedic, the number 2 to number 6 is already existing. We want to expand it further to increase the support value. This also includes number 7, open heart surgery. Physical medicine and rehab, consulta package. We already want to implement what's in the law, that every Filipino is assigned to a primary care provider to help them navigate the health system. This will be especially useful to people in the rural areas or our indigent sector, which they said parang ayaw nila mag-avail because they're not very familiar where to go to and all that. So dito, if you're assigned to a primary care provider, they will help you navigate the health system. We are working on severe acute malnutrition, which is still a very high incidence in our country, mental health, and increasing coverage of our COVID-19 benefit package. So what are the identified ways forward of PhilHealth? We, together with the Department of Health, we plan to assemble a special technical surge team to accelerate, to focus on developing, rolling out the universal healthcare benefits. We are integrating with the PSA, our database, so that we will be consistent with the deaths of our country at hindi na babayaran yung namamatay na. So we are in talks with the PSA. Digitization of our claims processing. We're really focusing on our claims processing at the moment to optimize efficiency and match new payment system. We are conducting experimentation sandboxes to test other policy ideas. So lastly, earlier I said that satisfaction of PhilHealth was perceived to be very low, at least from the point of view of central office, after the 2020 crisis. But I was very happy to hear the results of Sir Juni's survey, and it coincides, or it's consistent, with this survey done by Novotrends. Novotrends is also a third-party surveyor. They do their surveys, sometimes it's every 2 years, sometimes it's every year. Before 2020, before the crisis, I'm proud to say that PhilHealth was always number 1 in terms of most trusted agency, with a score of around 93 to 95% trust rating. In 2020, they did another survey, and that was the year of the crisis, when PhilHealth was always in the news, and they got their data on that year. So when they presented at the end of the year, I was expecting already a negative rating, or at least 50% or less. I was pleasantly surprised that our rating in 2020, hindi na kami pinakamataas, but at least it was still 85%. I'm not emotional, napapaubo lang ako. It was 85%. And tuwang-tuwa na kami niyan, kahit hindi kami number 1. Kasi it's not far from 90. So hindi sa pwede na but at least hindi siya masyadong bumaba. Now, in 2021, nag-increase siya We're now at 90.19% satisfaction rating. And I wondered why. Kasi from the point of view of central office, it looked already so hopeless. No? And natutuwa ako, and this is consistent with what the results show, that the trust, Sir Juni mentioned this, trust is based on their dealings with the agency. Tama yon, because the way the survey was conducted was they interviewed people who has availed of the services of PhilHealth, lalo na doon sa amin local health insurance offices. And most of them gave very high trust rating pa rin. So I've been telling our region, sila ang nag-save ng PhilHealth. The perception of PhilHealth looked very bleak from the central office, but at the regions where the services were being given, we still retained trust from our members. And that's because of the benefits we feel, that's the benefits that we give, and the perception that PhilHealth is needed, lalo na pag may medical needs and emergencies. So with that, despite the current challenges posed by the pandemic, PhilHealth continues to weather the storm and deliver uninterrupted health care services throughout the country to secure the health of every Filipino against financial hardship in this global scourge. So with that, thank you very much, everyone. Thank you for inviting me. Keep safe and choose health all the time. Thank you.
Thank you very much, Dr. Domingo, for that very comprehensive presentation, and also for touching on MAP's policy recommendation. And we will now commence our panel discussion, beginning with the reactions from our two invited panelists, who represent stakeholders of PhilHealth in the respective areas. We will ask them to give their 5-minute opening statement, and we start with the President of the Private Hospitals Association of the Philippines, or PHAP. Please welcome Dr. Jose de Grano.
Okay, good afternoon, everybody. And to, of course, our guest speaker, my friend and partner. He's a partner, private hospitals, partner po ng private hospitals, PhilHealth. Kahit minsan nag-aaway kami, partner pa rin kami. Okay, Universal Healthcare Law defines equitable access to quality and affordable healthcare services for the Filipinos. And of course, financial risk protection. Yun po ang ini-emphasize ng Universal Healthcare Law. It is quite a good law if we look at it in its objectives and mission. Our distinguished speaker is part of PhilHealth, one of the two biggest or main agencies tasked to promote and boost or advocate the Universal Healthcare Law. The other one, of course, is the Department of Health. Private hospitals, even though a part of the healthcare system, are still considered business enterprises. And though endowed with humane values, it is still a private business. Its vision and purpose, it is an organization managed and funded by private investment. And what's happening, or probably in the future because of the Universal Healthcare Law, they will be treating the private hospitals at par with government facilities. Is it because these hospitals are endowed with humanitarian purposes or with compassion and sympathy that they will be treated like government facilities? Who among our businesses here have no humanitarian factor in our organization? Of course, everybody has an element of humanity in them, giving out our best for the betterment of our customers, for the best outcome of whatever we try to manage. In everything we do, we are endowed with kindness, compassion, and humanity. Then why are private hospitals and healthcare industry being treated or are going to be treated like that? Maybe our legislators have forgotten that most often than not, they go to the private hospitals for their health services, their doctors, their diagnostic examinations, and who among them will go to the public hospitals? Well, maybe during the election time and also when giving out dole-outs and distributing donations to the patients of these government facilities. The UHC was specifically made for government facilities. Private hospitals should also be treated well like government hospitals, but it seems they somehow overlooked it in the formulation of the Universal Healthcare Law. In the Universal Healthcare Law, if you examine it very well, the private hospitals only exist as a part of a network. Well, if you join the mixed or the public-private network, they're not even mentioned as the primary center of care. They are just mentioned as referral points. Again, this is how we perceive the new Universal Healthcare Law, unless there are some amendments and revisions in the other provisions of that law. We still think that its objective is to eventually get rid or move for the extinction of the private hospitals. I'm sorry for thinking that way, but I am right now seeing the vision that government hospitals will be established in every region, in every city, in every municipality, even with the existence of our private facilities. And of course, people will go to the government facilities because of the financial risk protection that the Universal Healthcare Law promises. The question is, who is really picking up the tab? Is it PhilHealth? Is it Department of Health? Is it the government? Or is it the private hospitals? When you are admitted at a hospital, as a PhilHealth member, you are entitled to the benefits of being a member. For example, if you are pregnant and you need a cesarean section, your benefit includes around 19,000 pesos. That includes hospital bill and the professional fee, which is around 7,600. Who shoulders that? The hospital files claims and within 60 days and awaits reimbursement of this 19,000 pesos within 60 days. So that in essence, and they will wait for reimbursement for another 60 days. So in essence, it's 120 days advancement of these benefits of the members. However, if there is a problem in the evaluation of the claim, it may become RTH or return to hospital, and that will involve another 60 to 120 days. If the claim is denied, the problem, of course, is bigger. So the question is, who really picks up the tab? During the pandemic and for COVID cases, the moderate cases has 147,000 benefit. The severe ones, 333,000. And the critical, 786,000. These are advanced by the hospital for the patients. During the surge of the pandemic, the allocation is around 20 to 30% of the beds of the hospital for COVID patients. So if you have 100 beds, you allocate 20 beds, at least 20 beds for your COVID patients. So if you have 20 beds with moderate pneumonia, that is 147,000 times 20 patients, easily 2.9 million being advanced by the private hospitals for our members. And imagine if we are not paid in 120 days. Who will survive that? That is what happened during the pandemic in 2020, 2021, and until the early days of 2022. So much so that the unpaid claims reach 25 billion pesos. Although, right now, I think they have already paid half of it. That's what PhilHealth is saying. And who is picking up the tab? It is not PhilHealth. It is not the Department of Health. It's not even government. It is the private hospitals. The private hospitals, it's healthcare workers, the doctors and the nurses who sacrifice their time, of course, their safety, and some even sacrifice their lives. So you know why there was a move then to disengage from PhilHealth. Because a lot of our members can no longer sustain their operations. Some have resorted to downsizing. Some have reduced the working hours of their employees. Some have gone to the bank and requested for loans. Some have sold properties so that they will be able to pay the payrolls of their employees. 2 of our members' hospitals have to close, and until now have remained closed. Some of us have remained partially closed. Why? Because we have downsized our allocated beds, our authorized bed, from 150. Some have gone down to 90 beds. Some have gone down to just 50 beds. And then you ask, who is picking up the tab? In essence, our hospitals, the private hospitals, the healthcare workers, well, whether public or private, they pick up the tab. They are the first to fight. They are the first to go. Good for the government facilities because they are funded, they are subsidized, they are given a budget, whether they work or not, whether they have patients or not. The private sector is different. We are not subsidized. We do not get a budget from government. Yet, we serve around 60 to 70% of our population, and we contribute how much? We give much because we are part of the direct contributors like you are, whose premium payments are raised 5% every year. And of course, like most of us present here, are the doctors, nurses, and other professionals in the hospitals. They contribute a huge amount to as direct contributors, amounting to probably 4 to even 7 billion of the fund of PhilHealth. So again, who picks up the tab? Of course, probably it is us, the direct contributors, we fund the government, we fund PhilHealth, we fund the hospitals. And sometimes we're waiting for the reimbursement. We, the direct contributors, use the private hospitals to advance our benefits with no assurance that the money advanced will be reimbursed or not. Well, again, the question of who picks up the tab, the hospitals, the doctors, the healthcare workers, and of course, that includes you, the direct contributors. Thank you.
Hello. Hello, good afternoon. My name is Ellen Fulido. I'm currently the president of the People Management Association of the Philippines. Good afternoon to Sir Juni, to my colleagues, Dr. Jose De Grano, of course, Ms. Shirley, Dr. Shirley Domingo, of course, Ms. Alma Jimenez from MAP. Thank you so much for inviting us. We're going to give you a very short thought about the Universal Healthcare Act, no? Or Republic Act 11-223. As we say, you know, PMAP has been around for, we're turning 66 years old come October 2022. And we're an association of people managers who are supposed to be the preeminent HR organization in the country. When we say healthcare system, who picks up the tab? I probably would agree with Dr. Jose De Grano for saying that for the most part now, it's being absorbed by the contributors, by the members. PMAP is composed of organizations from private, even to government agencies. In fact, PhilHealth is also one of our valued members in PMAP, as well as SSS, GSIS. So we're across all industry, all sectors, both private and the government. I would just like to say this on behalf of PMAP, because we in PMAP would really espouse what is stated in the law. We're bound by laws, especially labor laws. And whatever pronouncements that we get or that are issued by the government, we are duty-bound as organization to make it known to our members that we are, we have to comply with whatever directives the government would issue insofar as promoting employee welfare is concerned. In PMAP, we espouse the people first principle, meaning we will always uphold the safety, wellness, and health of people within our organization. And that being the case, we therefore support the government's move to implement across all levels, across all organizations, the Universal Healthcare Act. More than any other time in our lives, that during the pandemic, we're more than 2 years into the pandemic, we're not even out of it. I don't know if the government will even declare that it's already endemic. But during those difficult moments, I think while there's an issue, there's a big controversy surrounding the agency, PhilHealth for that matter, I think none of us during that time, at the onset of the declaration of COVID-19 and the lockdown, none of us was prepared to really address the issue. We were fighting a virus that cannot be seen. I, myself, in the HR profession, was assigned in the command post of my organization. I'm in the media industry. And we cannot really comply with the lockdown. We're into news, we're into public service, and therefore, we are obliged to still continue working 24/7 to gather the news, to deliver the news, to carry out public service, because that's our duty in the media industry. And therefore, looking back now, Had we known what the medical professionals know by now, we would have probably addressed it differently. While there was a controversy, it's kind of difficult for us. We cannot just point accusing fingers to anybody because, again, as I said, none of us was really prepared to address the issue at the time. And we were all scrambling onto our feet in order to fight the virus. The biggest setback, I think, is the budget. All right? Even us, we were banking on the government support. We realized that this cannot just be handled even with the large corporations. PMAP has grown in numbers all over the country. We're 29 chapters with 51% now of the membership being MSMEs. Now, how do you support the MSMEs? Even large corporations, like I've been with the medical center. I used to work with one of the biggest medical centers in the country. I've been with big conglomerates. And not everybody, not all organizations will be able to provide well for the hospitalization and medical benefits of their employees. Most of these organizations would provide HMOs. Luckily for me, in my company, we pay 100% of all medical and hospitalization benefits of our employees, company administered. And the biggest single expense that we have would be for medicines. Medicine reimbursement. That's the single biggest expense that I would have every month. But how many of the organizations, especially the MSMEs, would be able to afford that, let alone provide an HMO? If you talk about a small business in a rural area, so you go to Agusan del Norte, a place like Cabadbaran, Hinigaran, in Negros, with small businesses there, operating a small restaurant. How many would be able to provide medical and healthcare services? I think this is one big area. We believe that this is one area where we would need the services of the government, PhilHealth for that matter. Yes, we would need their services. I think despite being surrounded with all these controversies, let's give them a break. From our point of view in PMAP, what we can do to support the government move, especially for PhilHealth, because now, in fact, based on our own observations and based on the sharing of our member companies, the next pandemic is mental health. Mental illness is the next pandemic because for most of us who were locked down, for most of our kababayans who lost their jobs and were displaced, for most businesses that closed during that time, isn't it stressful to be losing your job, to be displaced? Mas malaking kalaban yung kawalan ng laman ng sikmura. Ano ipakakain ko sa pamilya ko? Right? Di ba nakaka-stress yun? Hindi mo na nga mararamdaman yung gutom eh. Mararamdaman mo yung iniisip mo. In fact, even employees in the private sector would experience mental health. For some of us who have been used to working face-to-face, all of a sudden you're enclosed in a space, you're just in the confines of your homes. Hindi ba nakaka-stress yun? Nakaka-stress yun. Because a lot of sharing would show that while you're working from home, you're multitasking. Ma-attend ka ng webinar, ma-attend ka ng meeting, nagluluto ka ng pagkain mo. Right? Nag-tutor ka sa anak mo. So, in fact, in the PSA report, there was a huge fallout from women workers. Why? Because most of the women became teachers and tutors during that time. And how do you have access to medical facilities when you cannot even go out? Now, I think the challenge now, which we will be supporting from our organization's point of view, is to how to bring the healthcare services to the level of our kababayans in the rural areas from the smallest barrios or sitios. Napakaganda nung konsepto. Ako, personally, I support that. But the challenge now for us, not only in PMAP, but for all organizations, how do we support? How do we support now this moving forward? I think from our end, what we can do is to really enforce due diligence in the way we do things. When you apply for business permits, for those of you who have businesses, you cannot even secure business permits without paying your taxes, without paying your dues to the local government, and what's more, you cannot operate a business without enrolling your employees to SSS, PhilHealth, Pag-ibig, etc. So it's now a must. So if you are able to do that, and if you are serious in operating your businesses, I think this is something that you need to comply with. Biruin mo, kung di ka makapag-contribute, di ka makabayad ng dues, 3% agad yun. Hindi mo mabayaran yung SSS, that's a criminal law, that's 25%. Di ba? So, automatically, it shuts you off. But I think the biggest challenge is that while we have eased the restrictions to revive the economy, I think we also need to help and build the capability of our MSMEs so that they become compliant to the collection policies being mandated by the government agencies. So therefore, it's a shared responsibility for all of us. For all business owners, employers, and the employees alike to contribute towards achieving that goal. You know, access to medical health services and facilities is one of the United Nations Sustainability Development Goals. But if we all pull our efforts together, I think we will be able to do that. We just have to take small baby steps towards achieving that. But the call to action now, from our point of view, is let's all do our share. Let's contribute towards that end. And let's help our government agencies by, exercising due diligence, good corporate governance, and then instead of us looking at the negative side, I think we need to look at the positive side. Hindi man tayo magkaroon ng sarili nating CSR programs, let this be an inherent CSR program for all of us as employers and employees alike. I-share natin, lalo na dun sa mga mahihirap nating kababayan. So with that, thank you, and we're ready for questions. Salamat po.
Thank you very much to our panel of reactors and of course to the comprehensive presentation of Dr. Domingo. There are microphones on the floor. We'll open the Q&A now for your use, so please be brief lang. Let us avoid making speeches, and please wait to be acknowledged before you ask your questions. We were supposed to start it, but since you're standing there, we will acknowledge you first.
Yes.
Go ahead and please ask your question. Please identify yourself and your organization.
So I'm Benedict Randang, member of MAP and from First Circle. So I'd just like to commend PhilHealth. Last year, April 1 to 7, I got hospitalized to St. Luke's for severe pneumonia, COVID. And I was surprised that I didn't have to pay any single centavo sa St. Luke's BGC. My bill was almost 320,000 and PhilHealth covered all of it. So thank you. Yun lang po.
Wow, thank you very much. Ano pala yun? Appreciation pala yun kay Dr. Domingo. So,
maybe, Alma, do we have questions from our online audience? There are none?
Junie, ikaw, do you have questions?
Well, actually, Dr. Domingo covered a bit about the policy recommendations of MAP to upgrade the public health system by overhauling PhilHealth's leadership and management. And you touched on that. But, we also spoke about including investment in technology-enabled management systems and private outsourcing of certain functions. What steps are being taken to address these concerns that resulted from the many issues that cropped up at the height of the crisis?
Yes, thank you for that. I think the number one concern of our members and our providers are really claims payment. That's how we are judged. And admittedly, lahat ng dumaan sa aming president, yan yung number one nilang in-identify, automation of our claims processes. And therefore, we are currently in discussions with maraming trucks, no? One is outsourcing, the other one is a PPP, a joint venture, not PPP, joint venture, and others looking at offers from abroad in automating our claims processes. Kasi yun ang pinaka-visual, yan ang pinaka-nakikita ng mga providers. And we recognize that. I agree with everything Dr. De Grano says, everything. No question. And therefore, we really have to step up our game in terms of claims processing.
Well, thank you very much. Are there any other questions from the floor?
Sige.
Please.
Good afternoon. Thank you for expressing all the views of the different sectors. I am Betty Au of Business Innovations Gateway. I'm a naturopath practitioner. I also manufacture supplements. Hearing from all, I think our topic today is who is picking up the tabs. I think it is us, personally, who are picking up the tabs because our contributions go to PhilHealth. And of course, the private hospitals, some of them, they are also shouldering kasi I understand some of them has to close shop because they were not able to collect from PhilHealth. But then, if you take a look at it, most of the contributions that go to PhilHealth come from the middle class. Kasi sila yung working, the working class. When your contribution, when your salary is very high, you still pay up to only a certain level. Now, so if the middle class is paying more, then supposedly they should be enjoying more of the benefits of PhilHealth. With the Universal Care Program, let us look at other countries. For example, this is my personal experience. My daughter-in-law was giving birth in Canada. And we know that Canada acts the same way as the US, di ba? Universal healthcare sila, you pay contribution. Imagine she's going to give birth. Sabi nung hospital, we have no bed. Please come back tomorrow. And I told my daughter-in-law, I said, no, you're going to give birth today. I'm pretty sure. Kasi nag-break na yung water bag. So as you can see, that is one of the pitfalls of universal health care. So my suggestion is, I don't know to whom I can address, no? But I think the best way is, I don't know if any of your organizations can do more for preventive health care. Because I understand a lot of the Filipinos, they do not understand magkasakit sila. They don't know, ano ba yung sakit ko? Ano ba yung dapat kong gawin? What should I do? When in fact, sometimes a simple problem can already be solved through like a home care or medicine. Pero imagine they still have to be hospitalized. And then the problem gets aggravated. For example, looking at the figures of PhilHealth, number one is dialysis. Okay, we know there's a racket there, no? But then, comparing one patient, one friend from Hong Kong, they don't just recommend dialysis right there and then. Mas ano sila they try to, I think they do, don't know how do you call this, yung sa bahay nagda-dialysis? Oh. So they try to do it that way first. Hindi yung immediately, oh, mag-dialysis ka na. So, with preventive healthcare naman din, what can I do? Kasi at the stage na pwede pa siyang ma-save, di ba? Why wait until you cannot save the kidneys anymore and has to go dialysis when you can do something to prevent it? Yan. So I hope, those are my food for thoughts for each one of you. So I don't know if you already have your programs. Yan.
Thank you very much, Betty. Do you have a reaction, Dr. Shirley?
Yes, thank you for that, Ma'am. Your comments on dialysis first. You were talking about peritoneal dialysis. You know, Hong Kong has this policy of peritoneal first. They call it peritoneal first. They have very strict, this is a very strict policy that you cannot go into hemodialysis unless you are assessed for peritoneal dialysis, because peritoneal dialysis is more convenient to the patient and it's less cost and nakaka-recover ka agad medically from a peritoneal dialysis session compared to a hemodialysis. We also have that policy here now, but it's very hard to implement strictly because of a lot of factors. The doctors, marami ng hemodialysis, it's hard to change to peritoneal dialysis. Marami pong factors yun, but we have that policy. Wala naman masyadong racket. Siguro si Dr. De Grado will talk about that, not me. But I'll give the mic to him later. Preventive care. Yun na yun talaga ang na-mention ko earlier, yung konsulta. That is the contribution of PhilHealth to preventive care. That's the emphasis of universal health care, going back to preventive care. And we have this consulta program, which I explained earlier. It's taking off only because of the lack of providers, but we are working on that. Tumaas na kami from a very small 30 lang yan, less than 100, ngayon 400 na. And we're hoping to have more providers before we announce it in media. Ayaw namin mag-announce in media kasi it will fall back on us. Wala kaming providers eh. So once we have a lot of providers, then we announce, create the demand na, and announce it all in media. So I'll pass the mic on to Dr. De Grado.
Yes po, actually, yung konsulta, parang yun po ang talagang initial step sa sa universal healthcare. Everybody has to pass through a primary healthcare provider. Parang ganun din naman po actually sa abroad eh. Di kayo pwedeng dumiretso sa specialist. Sa Australia, sa Canada, sa iba. Then you have to pass through a GP. The GP will refer you to a specialist if kailangan. Kailangan na ganun. And that is the essence of the universal healthcare. The problem is, ganito po, baka marami kayong mga anak, nagdodoktor, magkakaroon ng kaunting yan eh, yung dilemma. Magpa-practice ba sila dito? As a general practitioner? Tapos na ako ng ng specialty, surgeon na ako. Sino magre-refer ng patient sa akin? Nandun lang ako sa clinic, maghihintay ako ng mga referrals. When in fact, right now, I can get patients directly going to me. Pero pag dumating po ang universal healthcare, you have to pass through your primary healthcare provider before you can go to the specialist. Magkakaroon talaga ng change, something, na medyo matagal-tagal yan. Sabi nga nila, progressive realization. Hindi ganun kabigla. Doon po sa dialysis, I doubt kung meron naman pong racket. These are patients na would really need at least 2 to 3 times dialysis per week. At yan po ay talagang kailangan nila. They are diagnosed as ESRD, end-stage renal disease, which means you're dead man walking. Kung gusto mong in terms talaga, they're just waiting. Actually, unless magkaroon sila ng transplant or anything like that, yun po. And of course, we appreciate na mas marami ngayon, 144 supposedly sessions, before 90 sessions lang, na ibinibigay ng PhilHealth. Basta bayaran lang kami. Okay lang yun, no? Basta bayaran lang. Okay po. Thank you.
Okay.
Doctor-
Siguro
Dr. De Grano, I'm not referring to the racket of
treatment.
Of treatment.
Yes.
The racket refers to a lot of dialysis centers that crop left and right.
Yes.
You know and I know that.
Mhm.
Okay.
That's different po. Yung
Yeah.
ibig sabihin, you don't need the dialysis pero sasabihin sa'yo, mag-dialyze ka.
Yes.
Diba? Opo.
Right.
Sige, thank you.
And also, I think, I think with the preventive naman, well, having a primary care, that's good, di ba? Kasi nga, na-educate din yung tao, at least, I don't know if you go through the experiences with HMOs, actually, a lot of the employees, they do not make use of the HMOs eh. Hindi nila alam eh. Diba? Kung ano mangyayari. Kasi for them, there's always that fear that, oh, why should I go to the doctor? Baka mamaya may malubhan akong sakit or whatever, so hindi nila iniinda muna. And the usage of HMOs, I don't know, you can make a study, diba? The usage of HMO is very small. But what I'm referring to, if I were, well, the good thing with the primary care, so you go to primary care, but the problem is, they will still feed you with a lot of medicines. So, and you know and I know that not all medicines are not good for everybody when we don't need it. In the same way na even kami nga, I'm telling people, you don't also take supplements left and right. Meron ding pwedeng, there's also a certain level that you can take. There's when you can take it, and why you should take it. So I think it's more of an education thing. So I don't know if you can probably include that in, I don't know kung sino ang pwedeng mag-take care of that one on the, And then if baka naman siguro, dahil sa madami namang contributions, yung mga employees, baka pwede nang isama ng PhilHealth sa program ninyo on preventive health care. And then much like yung COVID, we know that there is also a study ongoing. You know, I always tell people, the Philippines is very lucky. We have malunggay, we have turmeric, we have VCO. So why is it that during the pandemic, hindi prinomote masyado yan? Inaantay pa na okay, ma-finalize na to.
Thank you, Betty. We have to, kasi we are being signaled that the time is Do we have other questions from the floor? Because we'll fire probably the last question before, yes, Michael.
Yeah, good afternoon, and thank you very much for sharing insights about PhilHealth and the universal healthcare. Basically, PhilHealth is the government's national healthcare insurance, no? And I'm just wondering, of course, you can be compared to the private sector's HMO, and also with the other government, other countries' healthcare provider. So I'm just wondering, do you have study on the business models of this private sector's international HMO? Because it seems that they're doing good and well, no, in taking care and providing healthcare insurance on the private sector's company, as well as to the other countries' counterpart of PhilHealth, at least in our neighboring ASEAN countries. So do you have a study on the business model, and maybe how is PhilHealth fair, and what are the lessons that can be adopted so that at least we can improve more? Thank you.
Well, we have collaborations with other countries, especially in Asia. Like we're working closely with Thailand on their model there, especially on the provider payment scheme, no? But as to HMO, magkaiba talagang operations ng private HMOs sa PhilHealth. PhilHealth is a social health insurance. And there are a lot of features in private HMOs that are not in PhilHealth. Like one, we don't do, underwriting. Anybody can be a member of PhilHealth kahit 100 years old ka pa. A lot of people has been asking us, pwede pa ba akong mag-member 60 years old na ako? Pwede. We don't do that. No? Our contribution kahit tumataas compared sa HMO talagang ibang-iba. So mahirap mag-compare. We are social health insurance. The whole countries are membership based, and we are cross-subsidy, social solidarity, lahat yon. So mahirap mag-compare. Mahirap rin mag-compare with other agencies internationally because each of us have our own economic status. Siyempre, the first world country is rich enough to pay for everything. We're a third world pa ba tayo? O nag-advance na tayo? So yun. But we are working with them through associations and direct contact with other Asian countries. A lot of countries are helping us out. Germany, Korea, South Korea, Taiwan. Lahat yan are helping us out in aspects of our operations. Thank you.
And siguro just to add to the remark of Dr. Shirley, actually yung HMO is supposed to complement rather than compete with PhilHealth. In fact, that's the anomaly nga of the HMO premium, where the support factor, inuuna muna nila yung PhilHealth benefits before the balance could be applied to HMO. And yet, both the HMO premium and the PhilHealth premium is being paid for by the employers. So in effect, if, as Dr. Shirley mentioned, 57% is being funded by the support value of PhilHealth, balance na lang yun ang binibili ng HMO. And yet, the premium, if you compare the 5,000 of the 3,000 of PhilHealth versus the 15 to 20,000 of HMO, you will know from a CFO perspective na talo ka. Kasi ikaw nagbabayad ng premium. So you put that on top of your premium, and that's how much you're paying for for your health insurance. So we can have a forum with PMAP kung gusto niyo. We can discuss the economics of that. But that is may I just I'll just have to ask this question because you mentioned something about stages of care, and this is something that Dr. De Grano also mentioned. And I think siguro meron lang tayong konting difference dito ng point of view because I think this is a long time coming. Because if we look at very limited resources for financing healthcare, prevention should be the order of the day rather than treatment and curative services. And if we don't do primary care, that prevention is lost to us, and we keep on funding treatment and curative services, which is already the worst end of the stick in terms of financing healthcare. So I think I welcome that, except that siguro the thing here is we gradually transition to that stage, given the fact that we have very few players in the market. So this is my question. While the PhilHealth beneficiaries are being assured of fund support when they need health services, the capacity of the health system to take them in may be insufficient, thus creating a barrier to access. So how is PhilHealth going to work with the providers to incentivize them to increase their capacities or at least make investments in creating those facilities in those underserved areas? How do you propose to incentivize them so that the money, especially since it will have a very social service component, will make it viable for the private sector to come in and place their investments there?
Yes, I think that's a question that both of us should answer, Dr. De Grano and myself. If you remember one of my slides showing in one slide most of the provisions of universal health care, meron doon provisions on encouraging practice in GIDA areas, no? Like preferential accreditation and licensing.
That's
and all
what we
that.
saw, yes.
Yes, so maraming provisions doon, but progressive realization. No? And may I say that funding of primary health care is not that simple. It's complicated.
Yes.
Unlike inpatient care, isa lang ang player dyan, PhilHealth and the hospital itself.
That's why I said it has
Primary health care is more complicated because LGUs pay for it.
Yes.
DOH contributes also to it. PhilHealth is now contributing to it. We have to get our acts together with minimal resources.
That's true.
Yun lang masasabi
Agree.
ko.
So that's why I said it has to be transitioned into the operation for us to get this. So I think Arnold is signaling us na matatapos na daw yung time. So we will have to deliver our...
I will
Ellen,
just have
please.
to add to that, because we're talking about pushing more for preventive medical attention rather than, doing it palliative na lang or band-aid solution, curative na lang. In fact, in PMAP, we launched a program way back in 2013 promoting wellness in the organization. This means, because we believe also that wellness contributes significantly to the productivity of the employees in the organization. This does not necessarily mean that you really have to do Zumba or fitness workouts. Of course, we do in our company. But it's more of providing also information, services that can contribute to the knowledge and skills of our employees, be it mental health. Actually, financial wellness is also included there because you have to save up. Now that the government has launched Universal Healthcare Act, we cannot expect that things will happen overnight. I think from our end, we need to do our share. And the way to reduce our cost in our own organization is to really come up with a program that would prevent illnesses, from having an annual physical checkup for your employees. This is more preventive than just just seeing that your employees have now terminal cancers. That's more expensive rather than coming up with ways and means to promote health and wellness in the organization. So my take is, while we haven't seen really primary care centers, mushrooming all over the country where we can have access to the benefits that are due to us, then let's make use of what we have right now and improve some more.
Well, I think that ends a very exciting discussion. Siguro hindi dapat forum ang ginawa natin, dapat siguro seminar, na buong araw at hindi tayo matatapos. So, Alma, any last words?
Yeah, as I said, we really had that very engaging discussion, and it's correct, the COVID experience highlighted the urgency to build a more robust health system, one that calls for transformation, innovation, or expansion of directions. Government cannot do all this alone, and we'll have to partner with private sector in delivering these services, as you can see in the plans for the universal health care. Just to sum up the discussion that we had this afternoon, Junie presented that PHIC still enjoys a trust, but this has been declining for the past 2 years, and there's work for them to recover lost grounds. Dr. Shirley Domingo mentioned something about very, very good highlights. Outpatient will be covered, although in transition. The stages of care will be observed, and that's very welcome for me because I'm a big advocate of primary care. And it's good that Ellen mentioned that also, because it's not just a matter of funding healthcare. We also have to discipline the utilization of healthcare, because after all, healthcare is a resource. And the tendency kasi of most employers is to just encourage their people to use their insurance because binayaran na. But that's wrong, because healthcare consumption drives healthcare cost up. And if we are able to manage that, we are also contributing to the lessening of healthcare cost. We are glad about the expansion of the network of providers and maybe relaxation of some rules for licensing, expansion of benefits, and digital platforms for utilization and claims. Of course, Dr. Rene de Grano says there's a need to distinguish also the social services component of hospitals, not just them operating as business enterprises. And the law should also look into possibly incentivizing also private hospitals for what they do for the society. Ellen talked about the consideration of the micro, small, and medium enterprises in crafting rules and guidelines for PHIC, and welcomes the expansion of benefits that will address the health concerns of their employees. So each stage of care has their own set of providers and will play a role. But if prevention is the way forward, and should be, to prevent dissipation of public funds on curative services, then primary care provider is a must. So it seems that finally, pandemic forced countries across the globe to acknowledge that health is economy, as aptly stated by our former NEDA Secretary, Ernesto Peña. Poor health adversely affects economic productivity, and bad economy hurts health, through livelihood and incomes. So, Junie?
Well, as usual, very well said, Ms. Alma. And again, thank you very much, Dr. Domingo, Dr. De Grano, and Ellen Fulido. I now close the session and the meeting is adjourned. Thank you very much.